Hello, thanks for joining us. My name is Lee Kelso. This is HealthCall Live Online. We feature extended versions of the interviews offered on our weekly radio broadcast, the HealthCall Live Radio Hour. We're talking this hour about the statewide testing for COVID-19 antibodies. So we're going to try to track down those Hoosiers who have been exposed to the SARS CoV2 virus and learn more about why that is so important. So let me welcome to the program our guests. First up is Nir Menachemi. He is the principal investigator from the IU Fairbanks School of Public Health. Nir, thank you for joining.
Good to be here. Thank you.
You bet. Also with us is Dr. Lindsay Weaver. She is the Chief Medical Officer for the Indiana State Department of Health. Dr. Weaver, thank you as well.
Yes, thank you for having me.
Of course. Tell me what it is that you are going to learn as a result of this study.
So one of the things that probably is the most important thing that we're going to learn is the true prevalence rate for the SARS CoV2 virus or COVID-19. Up until now, almost all of the testing that has been done just about anywhere in the state has focused on people with a lot of symptoms and or people that were considered high risk. And so what we don't know yet is how many people out there in the community have been infected. By doing a random sample test, we'll be able to determine by gender, by race, by geographic area of the state, and by ethnicity, who has already potentially been infected, as well as who is currently infected with the virus.
And Dr. Weaver, what makes that important information? Why do we need to know those factors?
That kind of information will help us have a better sense of exactly where we're at here in Indiana. So because of how COVID-19 came to Indiana and the fact that we had limited resources when it came to testing, we have been testing the most symptomatic people. And so by doing testing like this, it really does give us a better sense of the people out there that maybe had mild or even no symptoms. So it just gives us a much better and clearer picture. And we're going to include that with lots of other data points to help maybe think where are we at now to help us think where we can go in the future.
Yeah, that's where I want to get to next is how will this information be used? What decisions will it inform?
Ultimately, when you think about the tests that occur in the clinical setting, those tests are most suitable for making decisions about the person that was tested. When you're testing at the community level, you're able to make community level decisions. And most community level decisions are policies. And when we think about things like social distancing policies and other stay-at-home orders, this will be a very important data point that will contribute to the complex decisions about those policies.
Can you help me understand? So if we know, for example, we're hearing reports that 15% of some communities, the community in Germany that tested all of its residents found a 15% seroprevalence rate. If we find those kinds of numbers, how does that lead a decision? What does that tell us?
So let me also just clarify, yes, the first wave of our study is going to get important information and maybe yield a number like what you just said, if that's true here in Indiana. But I think it's even more important to consider that by the time we get a second and a third wave, a couple of months apart, we'll be able to see changes in that seroprevalence rate in the population, which would be even more valuable information than knowing just where we are right now. I almost think about this as opening another front in the war against the virus. Yes, we know what to do, perhaps in the clinical setting. We have not yet figured out how fast the virus is moving through the population. And without that, we're not able to make as many, effective decisions on exactly where to deploy resources when needed. We might find that the seroprevalence in one area is much greater than in another area, suggesting that that area has already, the area where it has not yet been might suggest people there are more susceptible.
I get it. And so, Dr. Weaver, what is the individual who participates in this study going to be asked to do? What role will they play? How will they engage with you?
So we're asking the people who we invited to participate in the study just basic demographic information, your name, age, race, ethnicity, and then we're going to ask some questions about their symptoms, if they've recently had any symptoms, if they've been around anybody that has had COVID-19. And from there, they can sign up to get tested at a site that's nearest to them. And we have 18 sites all across Indiana over the next 5 days. And when they arrive, they're going to answer, again, some simple questions, go go over any recent symptoms once again, and then they'll get a nasal swab, which is let us know if they're actively infected with COVID-19, and then they'll also get a small blood test, and that's the serology and antibody test that we were just talking about. And then after that, they will get to go home, and then we'll get them their results.
So is that going to be a traditional blood draw, or is this the finger prick clinical site kind of test?
So for this, it will be the traditional blood draw.
Okay. So if you're a little needle shy, you need to know that going in. So glad we covered that. Of course, this is going to be done at no cost to the individual. How long is it going to take for me to get the results?
So we'll get the virology results in 72 hours is typical, so 3 to 4 days at the most. We have a pretty quick turnaround time for that. And then as far as the antibodies go, we're going to get them as soon as possible. So they're going directly to a lab to get run. But because this is the first time we're doing these serology testing, we don't know the exact turnaround time, but we still want to get it back to people within a week at the latest.
Gotcha. Mr. Menakami, how will knowing this information help me? What can I do with this information once I know it?
When you say like you, the individual person, or
yes, me, the individual testee.
So first and foremost, it will help you understand where you stand relative to the rest of the communities of Indiana. Our results will be able to break this out by district of the state. So you'll be able to identify whether or not your district might have been more affected already. We'll also be telling people individually what their test results are. So I think for individuals, there's really a win-win here. Not only do they get to determine what their current status is and whether or not their immune system demonstrates antibodies suggesting that they have been previously infected, but it also allows them to play an important role in helping the state advance our knowledge about where we are currently at the community level.
Well, are you comfortable using the results of an antibody test as not necessarily a qualifier, but an indicator that I'm safe to return to work in a public-facing position?
So unfortunately, we're not there with the antibody data yet. So while we test your blood and we're going to give those individual results back to people, whether or not your blood tested positive for antibodies, unfortunately, we don't know yet what that actually means for immunity. And so there still needs to be more data and more research. Even though you have antibodies, they may not actually mean you're immune. And if it does turn out that it did mean you're immune, we wouldn't know yet how long that actually lasted. So we're still early. Really, these antibody and serology prevalence studies that are happening gives us really great information about the community. It'll give us great information about the different regions of the state and the state as a whole. But at this point, other than just saying, yes, we found these antibodies in your blood, it doesn't give us too much information as an individual. But we're hoping that sometime down the road, as more information comes out, more research is done, that we'll get to a point where we could use it for those types of things.
And what is it going to take for that? Is your test going to tell me the number or the amount of antibodies in my blood, or simply detecting their presence?
So it's going to detect the presence of antibodies. I think another important thing to know is that given that these tests are new, that they're not 100% specific. So there is the opportunity for cross-reacting with other coronaviruses like the common cold, and every test is a little bit different, and we're figuring it out more and more with each day and each week as people continue to research it. So I think that we will see, I guess. This is how I'll end up with that.
Okay, I got that. So Germany, some other nations are talking about moving forward based on antibody testing to something they're calling, for lack of anything better, an immune certificate or an immunity passport. What's it going to take for us to get there?
So I would echo what Dr. Weaver just said. More research is what is going to have to get us to make that a meaningful certificate. Given the fact that all antibodies currently are able to tell us is the former presence of the virus in that person. If we don't know yet how much immunity and if immunity is conferred for how long, a immunity passport is relatively meaningless until we get more pieces of that puzzle figured out. Now, this is not to say that this is a bad move or a waste of resources. This is a necessary step as we continue to figure out the best way to defeat the virus.
So what percentage of the population, we know that herd immunity is allegedly achieved in the 67 to low 70% rate. What percentage are you going to be looking for as an indicator that we can start to relax some of the restrictions? Or is that a metric you're going to be monitoring for?
So I don't know that there's a cutoff that we have talked about yet, especially since this is the baseline. You mentioned some percentages in other communities. The truth is, we do not have solid evidence in almost any US community right now of what the current prevalence of the disease is. And so right now, we're just trying to establish that, given the fact that our state is one of the first states to do this in a truly random sample kind of way. I believe we'll be contributing also to decisions in other states who are going to either replicate our approach or use it as a proxy if they're unable to do testing at this scale. And so right now, I don't think we can promise any benchmarks or numbers. We're just trying to orient to what is out there.
So let me ask it this way. Let's assume that we exceed that 15% that the random sample on the street corner in New York achieved. Does that put us any closer to any policy decision?
So let me also say, importantly, the testing that was occurring in New York was not random samples. They, as I understand it, pulled up into a variety of different grocery store areas and asked people walking in and out of the grocery store to submit samples. That's a little bit different than random. Children are obviously less likely to be there. People who are have travel issues, are particularly vulnerable, or have other high-risk issues may not be the ones that are going in and out of the grocery store. And so our approach is a little bit of a different one, really designed to get a true representation of the Indiana population.
Yeah, I get it. So the supermarket concept is pre-selecting people who are ambulatory, healthy enough to go to the store, et cetera, et cetera. I get that. Okay, that makes sense. But then to that broader issue, though, of if we're looking at 15%, what does that tell us? And then if we do another test a month later and we're up to 30%, what does that tell us?
That will allow us to begin estimating the speed at which the virus has been spreading in the population. And I'll give a hypothetical scenario that I don't think is going to be true. If we find that we're above that threshold that you said for implied herd immunity, let's say we're at the 70-80%, that will tell us a lot right now that we just don't know anything about.
Sure.
On the flip side, if we're in the single digits in terms of prevalence, that would be a completely different story. And as soon as we get to the second wave, we'd see how fast we've moved. And that'll also estimate to us the asymptomatic spread of the virus, something that we've just not had a good handle on.
Got that. So what is the timing for phase 2? So we're going to do this in 4 different phases, I understand. First phase launching. When is the next round of testing coming?
That's planned for in about 1 month.
Are we going to go then monthly for 4 months? Is that the plan?
No, we're going to do in 1 month. So immediately in 1 month, later on in the fall, and then a year after we just started.
Okay. So, Doctor, let me put you on the spot here for a moment. Are you comfortable? Are we at a point where we can begin to lift restrictions in the early part of the month of May?
I think we're looking at all different data points. So I'm in close conversation with the hospitals, the hospital systems, and the physicians out there about what they're seeing. I think we have seen a leveling off of disease in Indiana, which is a great thing. I mean, it's good. I really think that every step that we have taken for people staying at home and what we've done with non-essential businesses is exactly what got us to this position, that we didn't see that big spike that we are expecting. Moving forward, it's going to have to be really, really slow. So we still don't want to overwhelm our healthcare system. we still want to pay attention to our ability to care for people when they need it. So it's just going to be a very slow process, step by step. And we're monitoring every day, staying in close communication. We monitor EMS data, ED admission data, how many ICUs beds are available, how many vents are available, and just the conversations about what people are seeing. And we use all of those to make determinations. So as we may start to relax a little bit, I also, want to communicate with people that if we do start to see a spike again, that we may go back and do a little bit more restriction. So I think the coming weeks and months will tell us a lot more information about what the following months mean and how we're going to approach this.
So I know everybody's big question right now is going to be, do you anticipate students being able to return to school in the fall? Either of you care to take a shot at that one?
So this reminds me of the governor pulling out his, crystal ball when a question like that is posed. And he, I think tongue-in-cheek suggests that it's very difficult to know. I think if we can continue doing the kinds of studies that we're talking about, continue working with the frontline physicians and nurses and the health systems, and the health departments continue to do the good job that they're doing, we'll eventually get to the point where we'll have enough information to say what's going to happen. But I think right now it's just too early.
Doctor, is there anything that I did not ask you think people need to hear at this point?
I think that I want to ensure people that we are working hard to increase access to testing for everybody, including vulnerable populations. So we already have several teams across the state that we deploy into nursing homes and other group home settings. And we're thinking about what is that next stage, right? How do we get testing to people's homes if they are disabled and unable to leave their home, but they're just an individual there? And we're working on mapping the state so we know exactly where all testing sites are, so we can provide that to Indiana. So you can just pull up and say, okay, these are the testing sites around me. I'm symptomatic. I need to go get tested. So we think that's really important. And by mapping that, we'll also see, where are there holes? Where do we need to make sure that we get someone in there? And that it's important that we continue to social distance and we continue to practice all of those measures that we've been talking about for several months. Even as we start to open up or relax a little bit, it'll only work if we continue practicing social distancing, wearing masks, washing your hands, covering your cough and sneezes, and not going to work if you're sick. I think that's going to be a really big change for people. That lots of us have gone to work with little minor colds and those things, but given the how much this illness varies from asymptomatic to very mild symptoms to severe symptoms, I think we're just going to have to be really, really conscious of that and say, it's not just for me, but it's to protect the people I work with and it's to protect their family members. And I also want to say that especially at-risk people, so elderly people with lots of chronic medical problems, that they'll really continue to need to practice those social distancing measures, and that we need to continue to support them as a community.
And Nir, let me give that question back to you. Anything I didn't ask you that you think people need to know?
I think, this is a challenging time. I think everyone understands that this is not just challenging from a health and mental health perspective, but also from an economic health perspective. And I'm reassured every time I work with the officials at the state that they really are working around the clock to beat this and to beat this fast.
Well, I thank you both for your time. That was Nir Menachami. He is a principal investigator from the IU Fairbanks School of Public Health, and Dr. Lindsay Weaver, the chief medical officer for the Indiana State Department of Health.